Deviation from normal, when to act. Dr. Madhur Maheshwari and Dr. will be discussing over this topic. Dr. Madhur Maheshwari is a consultant endocrinologist at Total Health, the Wellness Clinic, Andheri West, and also attached to Holy Spirit Hospital and Criticare Asia Hospitals. Dr. Anurag Leela is an endocrinologist at SAIT, GSMC and KEM Hospital. He has more than 80 original research articles in peer-reviewed endocrinology journals. Over to you, sir.
Thank you for that introduction. First of all, it's great coming to Akola. I would like to thank Neeta madam for inviting me. She's been a guide and mentor for me. She was the first person I met before I chose endocrinology as my specialty, and she's been very helpful throughout. It's very special coming to Akola because my in-laws are here, my wife is in the audience, and many doctors in the audience I consider family, so it's very special presenting here. As an organizing secretary, I would like to thank the faculty also for coming all the way from Mumbai, Nagpur, Nanded, and delivering talks, sparing a valuable Sunday for the audience. Thank you. So my topic is pubertal disorders and when to act. In many communities, puberty is celebrated, but if it comes early or if it comes late, it is a problem. As we can see here, puberty follows a typical Gaussian curve. Typically, it starts between 8 and 13 years in girls and 9 and 14 years in boys. And as we can see, there will be a subset of patients. There will be a subset of patients who are normal, who are just variants of early and delayed puberty, and they can often confuse us. And it is very important to investigate them in detail to diagnose a pathology. So can be very confusing. As we can see on the right, typically in the pre-pubertal phase, puberty is inhibited, and once we enter puberty, once the GnRH neurons get activated, the pituitary is stimulated, and then the gonads are stimulated. So any problem at the hypothalamus level, at the pituitary level, or the gonadal level can lead to a delayed or an abnormal puberty. What is also important is the progression of puberty. Typically, after onset, puberty should complete within 4 to 5 years. If it is incomplete, even then we need to investigate for pubertal disorders. The most important investigation is to differentiate whether it's hypergonadotropic hypogonadism, that is a problem with the gonads, or it's hypogonadotropic hypogonadism, either a problem in the hypothalamus or the pituitary. So we'll discuss some of the typical cases. We have Dr. Anurag, who has extensive work and research in this area for the difficult cases, and he'll be discussing some cases as well. So the first case, we have a 27-year-old male who's been married for 3 years. He presented with sparse facial hair. 3 years of marriage, they've not been able to conceive as a couple, hence his semen analysis was done which showed azoospermia, and hence he was referred. On history, he did not have any history of testicular trauma, swelling, torsion, and on examination, as we can see, he had long-leggedness, he had bilateral gynecomastia, and on his SMR examination, his testicular volume was 2 cc, very small for his age. SPL was adult and pubic stage was stage 4.
Madhur, anyone in the audience would like to take the case? What do they think about this? What are we dealing with? Definitely for a 27-year-old, hypogonadal features are definitely there. He's come for the first time with the concerns of infertility.
Androgen insensitivity syndrome.
Androgen insensitivity syndrome could be a possibility, and it's a very good guess. But the testicular volume is 2 cc, which is pretty low for that. But it could be a possibility, yes. More common possibility? Klinefelter syndrome. So we are dealing with a primary gonadal failure. So what are why Klinefelter? What are features favoring Klinefelter? And why not hypogonadotropic hypogonadism? I agree it is a Klinefelter. Be hypogonadotropic hypogonadism. Any points in favor of that? Arm span is not very much there. So it's not unicoid. Usually hypo would be unicoid. And Klinefelter will be long-legged. So that's one subtle clue. Gynecomastia is in favor of Klinefelter or hypo. And see, we can deal with it. It is very easy to differentiate hypo from hyper. Because you do LHFSH, you'll get an answer. So it's a very simple test to differentiate the two in the investigation. But clinically, yes, with the gynecomastia and long-leggedness, would put Klinefelter above hypo here. And complete androgen insensitivity, I didn't think of, but definitely if someone questions, yes, it could be a complete androgen insensitivity or a minimal androgen insensitivity coming with infertility. But in those cases, testicular volume of 2 cc is too small for the case. They would have a normal size testis because it's an androgen insensitivity and the testicular volume will be more than the same.
So gynecomastia favors hyper-hypo and goes against hypo-hypo. Those are the findings. So his investigations revealed raised FSH, LH, low testosterone, prolactin was normal, TSH was normal. So in any patient with delayed puberty or pubertal disorder, these are the initial tests that you would ask and you would get an answer in most of them. FSH, LH, total testosterone, prolactin and the thyroid. So this report was suggestive of hypergonadotropic hypogonadism. In a male patient, hypergonadotropic hypogonadism, you're supposed to ask for a karyotype revealed 47XXY. The final diagnosis was Klinefelter syndrome and he was started on testosterone replacement. If this had been this is a case of hypergonadotropic hypogonadism in a male. If you have a patient with delayed puberty, a short girl, always ask for an FSH. If it turns out to be raised, it is hypergonadotropic hypogonadism. In female, even there you have to ask for a karyotype and Turner's is a probable diagnosis there. So, moving to case number 2, he's a 24-year-old male, born of a consanguineous marriage. He works as a garbage collector in the BMC. He complains of absent facial hair, 24-year-old absent facial hair and small penile length. He gives a history of anosmia. Now this is very important. Any patient of delayed puberty asks for the history of anosmia. If it's positive, the diagnosis is decided on history itself. He had a family history also. Mother had hyposmia, decreased sense of smell. Elder sister had absent secondary sexual characters at the age of 27 and even had hyposmia. On examination, he was unicoid. On SMR, he was pubertal stage 1, pubic hair stage 1, testicular volume was 1 cc bilateral. There was no gynecomastia. So, any differentials here? Or, straightforward. The final diagnosis on history. Hypogonadotropic hypogonadism. So, his investigations also revealed a low FSH-LH, a low testosterone. Because all three were low, we did a prolactin as well. Prolactin was normal. The thyroids and the cortisol was also normal. So this was a case of hypogonadotropic hypogonadism. We did an MRI. MRI pituitary was normal. The olfactory bulbs also appeared normal. The final diagnosis was familial hyposmic hypogonadotropic hypogonadism. He was initiated on gonadotropins, HMGP treatment for 3 months followed by HCG. Dr. Anurag will be discussing more on that. The third case, it's a 16-year-old male, short stature and poor secondary sexual characters. He has intermittent headaches, uses spectacles but otherwise no temporal vision loss. On examination, he was short as seen in the growth chart, significantly short compared to his MPH and his pubertal stage, Tanner stage 3, testicular volume 5 cc bilateral. So similarly, we asked for the similar set of tests. FSH, LH was low, testosterone was low, prolactin was very high, 1000, more than 1000. cortisol was low, the FT3, FT4 were low with an inappropriately normal TSH, IGF-1 was low. So this was suggestive of hyperprolactinemia, and his MRI was done which showed a pituitary macroadenoma, and he was a case of macroprolactinoma treated with cabergoline. Now any patient with a pituitary adenoma always asks for a calcium profile. He had a raised calcium, that means he has a pituitary adenoma. He had a primary hyperparathyroidism. On imaging of the pancreas revealed NET, so he was a case of MEN1. So needs genetic screening of the family, genetic tests, and lifelong surveillance. Case 4, a 21-year-old male, second issue of a consanguineous marriage, complained of absent facial hair, small penile length, no anosmia, no headaches, no visual complaints, no family history, and he's always been short. He's growing slowly compared to his peers. On examination, his height was 159 centimeters for a 21-year-old with an MPH of 162 centimeters. SMR revealed a testicular volume of 2 cc bilaterally and no gynecomastia. So how would you like to investigate? Same set of tests. FSH, LH were low, testosterone was low, prolactin of 51, AM cortisol low, FT3, FT4, TSH all low. So, and for the chronological age of 21, his bone age was just 13 and a half years. So he was a case of pan-hypopituitarism. On MRI, he had an atrophic pituitary with a height of only 2 mm and an absent stalk with an ectopic posterior pituitary. So this was a case of pituitary stalk interruption syndrome or ectopic posterior pituitary syndrome. He was started on all replacements and hence treatment. So now these are the extreme cases where the diagnosis is straightforward. Let's move to the gray zone where you're not certain whether it could be hypo or whether it could be just a normal variant. So case 5, it's a 16-year-old male presented with delayed secondary sexual characters. 18 is the cutoff that is recommended. Until after 18, we can label them if they're not progressing. If the FSH LH is low, we can label them as hypo. But at 16, you're still confused whether it's just a variant of delayed puberty or it is a hypo. So no history of micropenis or cryptorchidism. No, there was a history of delayed puberty in the father, which can be very important to elicit. Can help us differentiate the two. On examination, his height was 158 centimeters, MPH, but his bone age was consistent with the MPH. There was a mild delay. Testicular volume was 2 cc, there was no gynecomastia. So, on my history, I do not have any major pointers except the positive history of delayed puberty in the father. His biochemistry showed low FSH, LH, and testosterone, but the other profile was normal. So we are still confused whether it is. We even did an MRI for him to rule out any organic cause or a mass in the pituitary, but his pituitary was normal with normal olfactory bulge. So a provisional diagnosis of constitutional delay in growth in puberty, which is CDGP, versus partial hypo. You cannot be sure even with the best of tests. Hence, a plan was to just observe and follow him after 6 months. So here I would like to involve Dr. Anurag and how can we diagnose at the age of 16 instead of waiting so that we can help start treating him early.
So the 4 cases we have shown, the idea was to give a complete spectrum. First was a clear-cut Klinefelter hypo. Second was anosmia and hypo. The third was because of, one was a prolactinoma and one was a EP. So 3 cases of hypo, 1 cases of hyper. In this case, how will we proceed? Anyone can have some comments so that we can go ahead with the next few discussion slides. So this was our pattern towards hypogonadism, which is more common in males. So we have taken the cases from the male counterparts. So this is what Madhur is pointing as a diagnosis of CGDP. It can still be a partial hypo-hypo or a hypo-hypo. Only time can tell us what will happen in this case. But at this stage, if parents are insisting, please give me a diagnosis, please refer me to best of the specialist, it's a big deal for me to know the diagnosis, whether it is CGDP versus hypo-hypo, what can be done, is something we'll discuss in the next few slides.
So as etiology of hypogonadism we have seen, so the hyper-hypo we can diagnose with the help of LHFSH, and before saying hypogonadism we should always rule out functional causes. So is there any systemic illness? So in this first case, this boy, the younger boy has come for delayed puberty, but the boy in the red shirt has come for delayed puberty, but the younger brother has outgrown him. So there is something systemic illness going in the child, and we found it as a CKD which presented with delayed puberty for the first time. So we should always rule out the child is apparently healthy before dealing with puberty. So we always get referral of the cases which are ruled out by the pediatrician that there is no systemic illness. But two conditions which are usually missed is celiac disease and a distal artery. So a bicarb test, a creatinine, and a celiac screen can be done as a part of a systemic illness, which can also be seen from a CBC or iron studies and give us a clue that we are not dealing with something which is not very obvious as a diagnosis, as a chronic illness. But now, ruling that out, which can be done with basic screen of investigations, we are left with hyper-hypo and hypo-hypo. So LH and FSH makes life very easy because we have easily available tests with chemi assays and the results come within 1 hour now. So we can differentiate the two. And once it is hyper-hypo, it is likely to be Klinefelter and we can do a karyotype. Now the most important question remains the middle two cases. Whether it is a constitutional delay in puberty or actual hypo-hypo, which is both pituitary and hypothalamic in origin. So when we look at these cases, so if you have a hypo-hypo, like anosmia is there that pointers towards hypo-hypo, or there is a mass lesion as in the case of prolactinoma, or there was a structural defect like EPP that points towards hypo-hypo. But those typical cases are far from few. And more common cases are CGDP where we have to differentiate them from hypo-hypo. So we have to use last cases like as Madhur had shown earlier, like we can have familial cases of hypo-hypo as he has shown a family of a sister and a brother. So there we are dealing with a hypo-hypo which was autonomic recessive inheritance or XLR in inheritance. They can have syndromic features like renal agenesis, anosmia, or any morphological defects which is pointed towards hypo-hypo. Or we can have prolactinomas like this or adrenopharyngioma. And just to tell you, these patients with big lesions in the brain, they grow tall. They may not be always short as shown in this case and as shown in the case by Madhur in the EPP. The child was not has come for a short stature. He was growing slowly and he was within the centiles at times. So they are unicoid rather than being short. So if they are not short, not ordering a MRI is not right. Still with cranios and prolactinomas we can get tall stature as shown in these cases. So coming to a more common scenario where we have to rule out the CGDP versus hypo-hypo, we have clinical and biochemical parameters. In the clinical parameters, what we look at is the height SDS, how far is the height SDS? If height SDS is near to the normal SDS, it is more like hypo-hypo. In CGDP, it will be -2 SD, whereas in a hypo-hypo, it will be -1 SD. So that gives some clue how away they are from the height SDS. And the testicular volume, if it is very severe hypo-hypo, it will be 1 cc. But if it is 2 to 4 cc, we are more towards CGDP rather than hypo-hypo. But these are not absolute things, these are just clues because there is a complete overlap between the two situations. Now we have this test called inhibin B. Though a costly test, ELISA-based test, not easily available, it is a very good test to differentiate hypo-hypo from CGDP. And at least the severe hypo-hypo will be differentiated. In the case Madhur showed, the CGDP case, the inhibin B was 88. So inhibin B was good. That means the FSH axis has started working. That is normal. So I will err on the side of CGDP in the last case based on the inhibin B value. So that gives me a clue that I am not dealing with, at least with a severe hypo, inhibin B is good, and this is more likely to be a case of CGDP. So this is a new test, but assay-related concerns and ELISA-based test, routine availability and a cost remains a concern with this issue. Conventionally, there are many stimulated protocols test, whether you stimulate HCG stimulated short test, prolonged test, GNRS stimulated LS test can be done to differentiate. But all these tests has to be read with the background that there is an overlap in the situation, and we can suggest more towards CGDP or more towards hypo by doing these tests. So as coming back to the Madhur's case, we can do these tests. We can do a GNRH stimulated LH test, which is simple, with GNRH 1 hour LH value. If it is more than 2.8, it is more likely to be CGDP. If it is less than 2.8, it is more likely to be hypo. That is one test I would like to do in the case which Madhur showed me in the last. And that can give me a higher confidence, no, I am dealing with CGDP along with the inhibin B to diagnose the case. After diagnosis, how does we help them is another question. If I diagnose a CGDP versus hypo, is the management different? Yes, the management is different. Conventionally with CGDP, we will put them on a short course of testosterone and the child HP axis will be active. Now we have an option of giving them retros for 3 to 6 months and activate the HPG axis as an oral tablet is the option in cases of CGDP. Either of the two things to activate the HPG axis is okay, but we can resort to doing nothing and waiting and watching is equally okay with the parents and if it is okay with this kind of treatment. So we can do nothing once the diagnosis CGDP is made and we just observe them, and within 6 months to 1 year, the puberty is not denied, it is delayed. It has to happen and it will happen. But when we diagnose a case of hypo, we have to initiate puberty induction. We don't put them on testosterone and we try to induce them with more physiological way of management with HMG and HCG. And by doing that, we try to mimic the normal puberty. And as in this case, we have taken this child from age of 15 years to a normal puberty. You can see the testicular volume at the end of the day was nice. He had normal sperm count. And then we have stored the sperm and now shifted the child to testosterone. And you can use the same principle when he wants fertility. Thank you. We'll move on to pre-puberty time context.
One quick case. So the other.
We have 2 minutes.
Okay. So the other side of the spectrum was precocity. These days we are seeing a lot of young girls present with breast development or menarche early in life. So this could be in as early as 7 years, 8 years. It is slightly early, but whether these are actual precocious puberty cases or whether it's just a normal variant needs investigation, then it could lead to a lot of psychological concerns. Managing a young girl who's entered puberty, not just for the patient but also for the family. So we had a quick case, 7-year-old female who presented with breast development since 2 months. On examination, her height, as we can see in the growth chart, is bone age is advanced, and she's in Tanner stage 3 of breast development pubic hair. Her investigations revealed that the FSH, LH were 4 and 0.65, and on stimulation with leuprolide, the LH was stimulated to up to 40. So this was suggestive of activation of or central precocious puberty. The estradiol levels were high and the thyroids were normal. So often it's said that if the patient is more than 6 years old, it's unlikely to be an organic etiology, or there won't be any height benefit if we treat with GnRH analogs. So, just a quick question and a quick response.
in this patient, we still went ahead and did an MRI, showed a small hypothalamic hematoma, and we started the patient on medroxyprogesterone acetate, lipo, and leuprolide. Was I correct in investigating her with an MRI, and should I have treated her?
Please give us 2 more minutes. So, since we have planned this PPT, you are correct in doing what you have done it. And so, precocity, it is a psychosocial issue and high benefits are there. We did a STEM test in a gray zone of 0.1 to 1 LH. We should do a STEM test. If it's more than 5 LH, central precocity. Sonography is adjoint. MRI, if you ask Madhur, it's more than 6 years. We go by numbers. There are 3% chances of finding a hypothalamic hamartoma. So I agree, doing an MRI in a small child is difficult. Sometimes anesthesia may be required and all. So, but if child is cooperative and it can be done without anesthesia, there is no harm in doing an MRI. As such, not harm, we can pick up a lesion. And second advantage, because we picked up a hypothalamic hamartoma, we have not done the genetic test. So in cases where there is hypothalamic hamartoma, we will not get a genetic etiology. So we have not gone ahead with the genetic test in this case. Had MRI been normal, we would have asked for a genetic test. And treating, as I said, premature Pilarkia, slowly progressive puberty we don't treat, because this case had an LH of, stimulated LH of more than 5, it's progressive. Beyond 6 years of age, in this gray zone between 5 to 8 years of age, cases with a severe bone age advancement and a higher basal B2 are the cases which will benefit in the long term in the terms of height. So based on these data in our case, we started the treatment with GnRH analog in this case, and so from the predicted adult height, the current height we predict it's more like a MPH. So we have definitely benefited in the height in our child. So we would like to not empirically treat everyone beyond 6 years, but based on the bone age and the estrad level values at baseline, we can consider treatment. Thank you.
May I request Dr. Madhur and Dr. Anurag to please proceed to the center of the stage to accept our congratulations.